part 3. Here I will talk about emotional changes after stroke. First, I want to just highlight some general facts about post-stroke depression. Post-stroke depression is the most common emotional change after a stroke. I want us to remember that about 1 in 3 of stroke patients will experience clinical levels of depression. In fact, in acute rehab settings, we will see about 1 in 5 of them experience post-stroke depression. You might wonder, well, why is this important? Post-stroke depression is highly associated with poor functional recovery, poor social outcomes. They generally report lower quality of life and satisfaction. It may impact their rehab treatment outcomes. It may also impact their thinking skills or cognition. And lastly, but most importantly, they're about 3.4 times more likely to pass away within a 10-year lifespan after the stroke. Again, there are a lot of consequences in rehabilitation. Individuals who have post-stroke depression generally have longer treatment stays, poor discharge outcomes, and they benefit less from rehab treatment. As I alluded to, they generally have longer days in the hospital, as well as more frequent outpatient visits. To better understand post-stroke depression, I want to encourage all of us to have a biopsychosocial framework to understanding this. What do I mean? There may be biological factors involved in depression. First, where was their stroke located? Was it in the left cortical region or subcortical regions? Generally speaking, left cortical regions are more associated with post-stroke depression versus subcortical regions. However, as a whole, the exact mechanism is unknown at this time. However, I want us to consider a couple of things. First, as I alluded to, there are some generally inconsistent findings in terms of lesion location. What I mean is not every single patient who've had a stroke in the left frontal area will exhibit post-stroke depression. And similarly, not every single patient who've suffered a stroke in the left basal ganglia area will exhibit what I call more reflexive crying or pseudobulbar affect. We'll talk about that more later, where the symptoms are more transient and they generally dissipate and improve over the course of the first couple of weeks. Next, it's important to highlight the left dorsolateral prefrontal cortex because in the general population, transcranial magnetic stimulation has often been very helpful in treating patients with severe depression. However, there's ongoing studies with that. In general, the literature does highlight and suggest that individuals who have left frontal strokes that are close to the frontal pole, in this picture it's highlighted in green, as you can see, those patients generally have an increased likelihood of then having post-stroke depression. I want to talk about psychosocial factors that are involved in post-stroke depression. Patients who had a premorbid previous history of clinical depression are going to be more prone to experiencing post-stroke depression. Likewise, their personality and coping style. So individuals who have more of a passive approach or who tend to feel like they can't do anything to help themselves. Again, these individuals are the ones who are likely to experience clinical levels of depression after a stroke. Lack of social support is a big one. And finally, their level of disability. So it's been found that individuals with severe impairment are much more likely to have post-stroke depression than those with mild impairments. So what are some of the things that we can keep in mind to assess for post-stroke depression? The first couple of days may be helpful in determining predictors of depression. You might find that you've seen some patients who've cried during the first couple of days of their hospitalization. And the crying has different qualities. There is what is known as pathological crying, where the patient experiences uncontrolled crying, and their crying is not associated with them struggling with anything. It almost feels reflexive. This type of crying generally is not associated with post-stroke depression. On the other hand, emotionalism, where patients start crying after you start talking about them, about how they've been impacted, this is more closely related to post-stroke depression. About 41% of those individuals soon develop depression after a couple of years. Most associated with depression are those who cry as a result of a catastrophic reaction. What I mean with this is, let's just say if you have patients try to stand or walk or engage in some sort of task and they're unable to do it, they have a catastrophic reaction in the moment, and it's shown by them crying in the moment, finding that it's a real struggle. This type of condition is most closely associated with then developing post-stroke depression. In fact, about 63% of them do develop it down the road. The general consensus, though, is that depression is more common in patients with left hemispheric strokes. With right hemispheric strokes, these tend to be more correlated to what I would describe an indifferent reaction. As I alluded to earlier, these are the patients who may show signs of apathy, lack of concern, lack of motivation, and even denial of their current symptoms. I want to spend some time talking about apathy, because this is a type of emotional change that is also common after a stroke. We see this in about 11 to maybe about 30% of our patients, and it's often misdiagnosed as depression because apathy, when observed, kind of mimics depression. You might see, flat affect in the patient, lack of motivation, not wanting to get out of bed, maybe just decreased self-concern. So it's important to tease this apart. We see that apathy is a lot more common among older adults, but it's often associated more so with deep posterior subcortical lesions. Next, I do want to take some time to talk about emotional lability. Some people describe this or characterize it and define it as pseudobulbar affect. This is where the patient displays uncontrolled emotions, whether it's uncontrolled laughing and crying. That's actually not related to content or what's going on in their environment. This is seen as more of a reflexive type of symptom and is noted in more subcortical strokes. Also, basal ganglia strokes as well. And lastly, mania. Mania is not as frequent, but I just wanted to highlight that it is another common, not common, but another emotional change after a stroke. Now that we have a pretty good understanding of things for sorry, let me stop that. Okay. Now that we have a good understanding of the various symptoms and emotional changes after a stroke, it's important to further assess. I want us to all key in on various signs of depression when working with our stroke patients. You might find that these patients may not want to drink water or just not want to eat much at all. They might take a much longer time doing the simple things that you and I do, display what's called psychomotor retardation. They might not want to interact much with others, not want to talk. These are individuals who might display some sleep difficulties, whether being able to fall asleep at night or when they wake up, being able to fall back asleep. And lastly, emotional lability, noticing periods and moments of sadness and anger and fluctuations in their mood. I often use the CITI. It's the Stroke Inpatient Depression Inventory. I find that assessment to be helpful because there is a cutoff score that correctly classifies 86% of patients who have post-stroke depression. So now that you've assessed these patients, what do you do next? How do you manage these emotional reactions when you're confronted with them? In these next couple of slides, I do want to make sure that I get you to the point where you're comfortable working with these patients. The first thing that I want all of you to attune to are behavioral observations. What's going on? I talked a little bit about this earlier in my previous slide, but I want to really emphasize this because it really helps us to have a better assessment of what's going on. So again, are these patients becoming more quiet or withdrawn? Are we noticing that our patient is starting to fixate on wanting to drink or talking about once they leave this hospital that they want to drink? Do you notice increased tearfulness and crying, especially when you find that they're alone and in their rooms by themselves? We might see that they're more irritable or snappy. They may have difficulty with attention and concentration, and you might find that they just can't focus on the task as well as before. Sleep is another common issue. Again, as I talked about earlier, difficulty falling asleep or staying asleep. And lastly, again, loss of appetite or increased appetite. With that in mind, I want us all to remember that along with the various stages of a patient's physical and cognitive recovery comes emotional stages of recovery. Every patient will experience some stage, as highlighted on the slide. They may be in the stage of just losing focus, sort of feeling what's going on. You know, I'm not sure what's happening. This is not for me. Treatment is not for me. They may be in the stage of minimizing the impact. Like, nah, you know, this will all get better. You know, it's going to get better sooner or later. It's not going to impact how I'm going to do at work or at school. You may find that some patients may be in the pit stage where they're essentially at the rock bottom. these are patients who really don't want to get out of bed or really feel hopeless. Or they may be in the stage where they're starting to let go of their past and they're starting to realize that their future is going to look very different. They may be starting to test the limits and see where they're at. So for example, they may try standing even though it's not recommended by the therapist. So they'll stand just to see if they can stand. Or they may maybe start eating something even though it might not be recommended. Others are in the stage of searching about the meaning of life. Why me? Why did this have to happen to me? Or similarly, am I going to get another stroke? How's my future going to look like? The last stage is the stage of integration. And this is the stage where we want patients to be at, where they start to incorporate their old self, their old hobbies, and start realizing ways to adapt and modify into their new self so that they can really lead a productive and independent life. Individuals in the integration stage tend to have the best outcomes. But again, when you work with stroke patients, they may be at any stage of this recovery process. So what do? What can be helpful? The first thing is normalize their experience. Meet them where they're at. Understand their reactions and to let them know that what they're experiencing is very common. Allow them to ask questions. Provide education to provide as much control as possible so that they can plan and prepare and know what to expect. Next, it's often helpful to make sure that we always focus on encouraging patients. Don't take away hope. Don't discourage them. Instead, provide constant positive feedback so they have some hope, some positive things to hang on to, things that are meaningful. So again, I want to emphasize that it's not a good idea to push patients into awareness when they're not ready, because likely you will experience resistance from them. Again, promote active engagement in rehabilitation by allowing them to take ownership, full control, be collaborative in the treatment planning, give them choices when possible. And lastly, to always be an advocate, to provide as many resources as possible to help them through the recovery process. The good news is that we can do a lot to prevent patients from experiencing post-stroke depression. The first is to have a solid, strong care management team. Always to provide a lot of information, education at all levels across the rehab process. We know from the literature that family and social support is a key factor to helping to motivate patients and to integrate back in real life situations. Also, we know that cognitive behavioral therapy and group therapy interventions are quite helpful as well. And lastly, there is growing evidence that use of an SSRI during the first 6 months to even up to a year can prevent the onset of post-stroke depression. I want to end with this slide in the sense that the prognosis for post-stroke depression is good. with treatment. Nearly 75% of folks who have post-stroke depression have symptoms that resolve after a 2-year period. So that's the good news. Thank you.